Hello and welcome to Dragon Bites, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales and one of the presenters for Dragon Bites. This week we're joined by Professor Orhan Uzun, Paediatric and Fetal Cardiologist at the University Hospital of Wales. He's going to start a whole new series of lectures with us, all on left to right shunts. We're going to start the first in this series today with an episode about Vein of Galen Malformations. Anyway, let's get started. Hello everyone. So I've been joined again by the excellent Professor Orhan Uzun, Fetal and Paediatric Cardiologist at the University Hospital of Wales. Thank you for joining us, Professor Uzun.
Thank you very much for asking me to join you.
Oh, you've been very popular. The podcasts we had from your cardiology series have been very well received by the people who've been listening in. So we're going to have a discussion today, and I thought I'd let you introduce our topic, if that's okay. So what will you be teaching me?
Today our teaching will take a different angle. I'm going to take you out of classic textbooks and make this a fun for you. And also relevant to day-to-day clinical practice. So today I'm not going to teach you about ASD in isolation, VSD in isolation, AV septal defect or PDA in isolation. Well, I will put them in one pot called left to right shunts.
Okay.
If you conceptualize the whole matter together, and it will make it long-lasting, and you will never forget them.
Fine. So we're going to think about the whole of this topic as shunting from the left to the right, but subcategorized into other areas.
Absolutely. It will be a summary. It will be honey and fruit of it, rather than using a lot of elaborate words and confusing you further.
Fab. Because it doesn't take very much to confuse me, Professor.
I get confused still. You're not alone, I can tell you. The reason I did this, left to right shunts are classified in books in various forms. But my classification and my advice to you would be to conceptualize from anatomical perspective, like we do with anomalous pulmonary venous return. We need to take the heart and the outside structures and put them together in the context of space. The shunts could be either above the heart itself, at the arteriovenous end, completely in distal portion of our body.
Okay.
That is a different entity, is not written in books, and we don't know much about it because it's rare. And the second, and perhaps one of the most common left to right shunt, at the atrial level. So we come into the heart, above the tricuspid valve at atrial level. And the third type of shunt is the most common one, intraventricular, below the tricuspid valve and mitral valve, and also below the aortic and pulmonary valves.
Sure.
So the intracardiac shunt can also occur in the ventricular level, below the tricuspid and mitral valves, and up to aortic and pulmonary valves. VSDs namely, and also AV septal defect, combining the two. So intracardiac shunt could be in atrial level, in ventricular level, or combining the two atrioventricular level. And then we have the shunts beyond the arterioventricular valves. What are they? PDA, which is quite common in preterm babies, and also a rare entity, sort of PDA, but without any long tube, direct communication of aorta and pulmonary artery. Do you know what it is called?
No, I don't.
Very rare.
Yeah.
Many cardiologists also probably did not see this condition, this pathology. It's called AP window.
AP window.
Aorta pulmonary window.
But it's essentially anatomically similar to a PDA, but without the tube, just a direct link between the two vessels.
Correct, exactly. And we'll talk about how it happens, why it happens, when it comes to that section.
Fab. So let me just make sure I've got this clear in my head. So we're going to cover this in, I think, 4 segments. So the first, we're going to talk about lesions that occur before the heart. And that have I got this right? Could this be anywhere in the body?
Correct.
Right.
But neonatologists would like it, particularly the one occurs in the brain.
Oh wow! Okay, I'm already excited to find out more about this. Then the next, we're going to head into the heart. We're going to look above the level of the tricuspid valve. So we're looking at intra-atrial communications.
Correct.
And then below that level will be our next grouping, where we're looking predominantly at intraventricular communications.
Correct.
And then we're going into our final category, which will be after the heart, and we're looking at aortopulmonary communications.
Correct. Exactly. Well done. I mean, see, if you put the picture as a whole, and yourself marvelously described, even within seconds of me finishing my talk, I hope the audience also will conceptualize this clearly, and they will enjoy it. I'm pretty confident, and I would be very interested in their feedback.
Yeah.
Let's talk about the first entity, which occurs at the arteriovenous junction. Start with the most relevant abnormality, would be a great interest to neonatologist as well as general pediatrician. That is the vein of Galen aneurysm. Such communication means that the arteries in the peripheral circulation do not have the gap junctions, do not have the boundaries to reduce the pressure and allow tissue exchanges, but rather arterial flow unimpededly goes into the veins, and they come straight back to the heart. As a result of it, there is an increased circulation. We call that high output cardiac circulation, or high output cardiac failure if it leads to cardiac failure. It is the only one which gives you left and right heart failure at the same time. It can happen in the brain. When it happens in the brain, you will hear a murmur in the fontanelles.
Oh wow.
So I am adding another spot for you to listen to.
I've never considered listening to the fontanelles before. Wow.
This is one of the conditions that you would look probably a little bit funny when the other people didn't appreciate what you're doing, but when you explain, you will look very smart when you detect such an abnormality.
Right.
This condition resembles and mimics persistent fetal circulation and shows itself as if there is pulmonary hypertension. So it is not uncommon, these babies, to be treated as if they had delay in reduction in the pulmonary vascular resistance, hence pulmonary hypertension. And guess what? Occasionally coarctation.
Oh, right.
Because of increased flow into the brain and still phenomenon, there is remarkable reverse flow from aorta back into the head and neck vessels. Hence, less flow goes to the periphery, and the isthmus, where usually coarctation occurs in the descending aorta, becomes so small, and the pulses become so weak, and sometimes this condition can mimic coarctation. So be aware, if there is such a baby with high output cardiac failure and showing signs of pulmonary difficulty, pulmonary hypertension, and you can't feel the pulses, put your stethoscope not only at the back, remember, for coarctation, but also in the brain.
Also in the brain.
That's a little tip for you.
Wow.
Oops, don't tell that to you.
So working my way through the pathophysiology of this, we've got this sort of high output blood flow from the aorta, and it's not meeting the normal resistance it would do prior to entering the venous system. So we then have quite a high pressure flow going into the venous system.
Correct.
And that's what leads to our sort of right-sided element of the heart failure.
Correct.
And also the pulmonary hypertension.
Correct.
You mentioned that we also have this high flow going.
I'm coughing because I'm absolutely astounded.
I just want I like just having these things clear in my head. So you mentioned that you have this high flow then going up towards the brain, I take it through the aorta and then up towards your superior circulation towards the brain. And because of that, so how come there's a high flow going in that direction, and there's a reduction in the flow going, via the rest of the aorta, leading
Wonderful
to
question.
Yeah.
Wonderful. Absolutely wonderful. There is a beautiful physiological phenomenon. It is called brain sparing effect. Body is designed, the nature designed our body and physiology to spare and protect the vital organs by redistributing blood flow from peripheral circulation to the vital organs in times of crisis. So it happens in many conditions. So blood flow is redirected from your splanchnic plexus, from your gut, from your skin, into your brain and coronary circulation.
Right.
And that is the element of it. And what happens in organs that is vital to our survival, they reduce resistance, and the peripheral vascular resistance increases to maintain circulation in those vital organs. Hence, if the resistance is low, blood would flow towards brain and other vital organs easily,
Right.
than flowing into the organs where the vascular resistance is higher.
So as such, would that mean that the babies who were presenting with this, in my head I pictured them as babies, would they present with perhaps cool peripheries then?
Correct.
Right.
Absolutely correct. And shutdown appearances, and like in pulmonary hypertension, and they would also have element of desaturation. These babies usually present antenatally and immediate postnatal period, and they would have cyanosis as well as congestive heart failure and increased pulmonary circulation and pulmonary hypertension.
Incredible.
And that's the first phenomenon. I think that is probably a new concept that we are introducing to our listeners. Same phenomenon can happen in other parts of our body. Like we can have a teratoma in sacrococcygeal region, or we can have arteriovenous malformation in the liver. So same findings might be expected in the liver. If you put your stethoscope on the liver, you might hear continuous murmur like you would hear in the brain.
Yeah.
Continuous murmur you expect to hear in these babies, systolic and diastolic, without any interruption. It can happen on your skin at the back if there is a large arteriovenous malformation. But to be able to hear the murmur, you need to have good amount of shunt.
Right.
Usually what we call it more than 1.5 to 1. So 1.5 of our cardiac output should be diverted into the opposite circulation. Less blood should be going to the systemic circulation. If the shunt is 2 to 1, so 2 volume goes to the venous system and 1 volume goes to 1 unit goes to the arterial system, then you would hear it easily.
Fine. So 1.5 to 1 would suggest that you've got 50% greater volume going towards the shunt than the rest of the circulation. You mentioned the lesion being in the brain first. Is that because that's the most common form that this sort of shunt takes?
Correct. This is the most common shunt that we come across in babies. I am yet to see a child with cardiac failure that was related to an arteriovenous shunt in the liver or elsewhere. We have seen older children who developed cardiac failure as a result of arteriovenous shunt, as a result of coronary fistula going into the ventricle, going into the atrium. But this is also exceptionally rare. And it's in fact, in my view, less frequently seen than the vein of Galen aneurysm and the peripheral cutaneous or liver or kidney or sacrococcygeal arteriovenous malformations.
Wow. Okay. So say I've seen a baby on the neonatal unit or something like that, and this is what I'm suspecting. This sort of high cardiac output lesion. How would I go about investigating whether my thoughts on the matter are correct? You mentioned putting the stethoscope where we suspect the lesion to be. Is there anything else I should be doing in terms of investigating the lesion?
Absolutely right. Yes, investigations are necessary in this condition. You hope that most of them would be detected antenatally, but I can tell you some of it may escape detection. It's not uncommon. First of all, ultrasound is readily available, but prior to applying ultrasound, you must always use your stethoscope. You must always use your clinical observation and palpation skills. Observation would show a breathless child, blue child, full pulses, and also increased cardiac impulse of the right and left ventricle. And when you did ECG, it would show increased right-sided as well as left-sided forces, and it would show tachycardia. Then you would move on to the next step, and they would be either readily available ultrasound in all neonatal units. You would do chest x-ray. By the time you call radiology, you might as well put the probe on the brain. You also get the cardiologist to do echocardiogram.
Okay.
Those are the investigations in a sequence I would do and recommend.
What would we, doing a chest x-ray, any particular things that we would find?
On the chest x-ray, you would see biventricular enlargement. Heart would be globally enlarged, and the pulmonary vascularity, the increased size of main pulmonary artery, size of pulmonary artery branches would be obvious and prominent on the chest x-ray.
Wow. And
patient also would have congestion findings.
Okay, so we might be looking at some like pulmonary fluid, plethora, yes. Yeah. So perhaps pulmonary edema?
Yes, in the perhaps advanced and worst case scenarios, even that can happen in fissures and also in interstitial spaces.
Wow.
Correct. And right atrium would be bulging towards the right lung fields. Normally it should not expand onto the right side more than any age, more than 2 fingers.
Okay.
Of course, depends on the size of your finger.
Yeah.
If you've got 2 big fingers, then you must say no more than 1 finger. If it is exceeding more than 2 fingers, that right atrium is abnormal. It's a little tip for you.
Okay. Wow. Okay, that's really helpful. So we're going to clinically examine this child, looking for the findings you've mentioned. We're going to get an ECG, we're going to get a chest x-ray, we're going to get an echo, and while doing the echo we can use that same ultrasound probe and have a look at where we suspect this fistula may be.
You would probably be able to do ultrasound before echocardiogram, because ultrasound is readily available in all neonatal units. In my view, all neonatologists and pediatrician must be taught and developed in terms of how to use cranial ultrasound in these scenarios. This is one of the conditions that would be very helpful, because it would show ... Can you feel the dots? Because you're after on call, you see?
Oh, right. Yeah, I am post on. I should point out that I am post night shifts. Dura mater.
Absolutely, dura mater. So we got the sagittal sinus, we got the transverse sinus, we've got the sigmoid sinus, and then we've got the confluence, so on. And any of these sinuses may be enlarged.
Yeah.
So dura mater sinuses would be enlarged, and vein of Galen would look incredibly big, enlarged, with massive, like spider net circulation between vein of Galen and the sinuses, and dilated sinuses of the affected one. And that is the ultrasound finding.
So we should also put the probe on the occipital fontanelle as well, Professor Uzun.
That's correct. That's correct. Do you think we should also put on the bones?
Yeah, well, I feel like the way you've mentioned it suggests that we should.
Yes, because,
but I would be grateful if you'd explain why.
Yes, because in neonates, still there are gaps between bones. Hence, if you come on the temporal bones, you would be able to see sagittal sinuses better.
Oh, right, okay.
And that is the reason. So it shouldn't stop you from going on the bony areas to find the interdigitations between the bones.
Wow, okay. That's something I've never tried in neonatology before, but I'll keep that in mind in the future. That sounds really interesting.
That's a little tip again. We will have a lot of tips in this talk.
Yeah, absolutely. Fab. So does that cover all the investigations, or have we missed anything at this stage?
Do you think the investigation is complete if you didn't bother cardiologist?
Well, I feel like right now I'm bothering a cardiologist.
You are not, in fact, bothering in the right way, because this is a teamwork, remember? Yeah. Everybody should provide their input. Because you're worried, femoral pulse is also not palpable. So you express that cardiologist. Also, you ask him to come and have a look at the baby and tell what the pulmonary pressures are like. So when cardiologist comes and does echocardiogram, or I do envisage in the future, neonatologist and pediatrician like yourself will be able to do basic echocardiograms. That is absolutely necessary. We should share our knowledge and skill. And you should be able to do 3-4 things. 3 things, in fact. 1, to look at the function of the heart. That is absolutely essential, because in this condition, function of the heart may be deteriorating, may have already deteriorated. So you can look at the size of the ventricles and how they are contracting. That's the first thing cardiologists will look. Second thing cardiologists will look at, the pressures inside the cardiac chambers. Is there a pulmonary hypertension here? And if there is, what is the pulmonary pressure? Then you need to formulate your treatment and decide on the appropriate management with medication, ventilation, nitric oxide, and so on, pulmonary vasodilators. And the third thing cardiologists will look at, the nature of shunt, where it is coming from. What is the source of cardiac dilatation? Is it at the atrial level? Is it at the ventricular level? Is it at the arterial level? Is it precardiac and in end organs, in the arteriovenous level? So that's what cardiologist is going to do. And of course, the fourth thing is to rule out other associated lesions like coarctation, look at the isthmus, and demonstrate supportive findings of vein of Galen aneurysm to show reverse flow.
So to show that the flow is going up towards the brain and we're losing some of the flow going down the aorta.
That's right. And also demonstrate in these patients there is no additional VSD, there is no additional AP window, there is no additional stenosis, and so on. That is crucial, because when you find one major lesion, then sometimes it is very tricky to maintain your attention in the way of excluding other abnormalities.
As in, you found a diagnosis and then you almost focus entirely on that, forgetting that you still haven't ruled out the others.
It is the most common mistake we all make. I would urge you to pack it and put aside and go on as if you haven't seen anything. But always connected. Leave some channels connected to that lesion.
Now that we've covered investigating the lesion, how would we get about to managing it?
Management has to be prompt, multidisciplinary, and it should be well coordinated by the neonatologist. First of all, symptomatic treatment, of course, diuretics to reduce the volume and offload the baby's peripheral as well as pulmonary circulation. Judicious use of diuretics, of course. If there is any cardiac dysfunction, then you should try inotropes, preferably inodilators, because we need to dilate pulmonary circulation. That's very important to reduce pulmonary vascular resistance. But when you dilate pulmonary circulation, then you will increase pulmonary flow further, and you will lead to further cardiac failure. So you've got to be very careful. Nitric oxide, again, will help, and it will increase pulmonary vessel sizes, but it will increase the shunt too. So it is very difficult.
I see.
So it has to be balanced. So you need inotropes, adrenaline, noradrenaline to increase the systemic pressure so that you can reduce right to left shunt through PDA and other fetal structures. So you need some vasoconstrictors, but you also need judicious use of vasodilators without increasing pulmonary circulation too much.
It sounds like it's a very fine balancing act.
Absolutely correct, very fine. And the most important thing here is to coordinate the care immediately with the 2 neurosurgical centers. There are only 2 centers in the UK who do operate on these babies. One is at Liverpool, and the second one is London, Great Ormond Street Hospital. So remember, only 2 centers, they coordinate. If one of them is away, the other one takes on. And these patients perhaps should be transferred in the safest way. Sometime air transport might be necessary. In the case that I mentioned to you from Peripheral Hospital, we coordinated excellently with pediatrician, neonatologist, and the Vein of Galen Surgical Center.
So are those the key teams that need to be involved then? So the neonatology team, your local cardiologist, and the surgical center for Vein of Galen?
Correct. Well, this is on the assumption of these babies will present immediately after birth.
Yeah, of course.
So you may wish to ask, are there any patients who may present later on?
Are there any patients who might?
Of course.
Yeah.
Of course there are. Those ones initially probably didn't have significant shunt, as I explained to you.
Yeah.
It was small, less than 1.5 to 1, and the shunt got bigger. So the amount of shunt was handled perfectly well by the person's heart, and it became obvious when the child reached something like 4 months, 6 months of age, sometime earlier, but beyond the neonatal period. And in those babies, then you have time to do different operations because the condition is not dire and the patient is not in profound heart failure. And some centers attempt to do interventional closure of these communications. So you can either close them surgically or you can close them interventionally. Interventional closure is the preferred method.
Right.
Even in neonatal period, by using certain products. The material neuro-interventional person use or interventional neuroradiologist use, either glue, special glue, it just occludes the end vessel, or we use coils, metal coils, titanium coils. And those coils, of course, become epithelialized and block the shunt as much as it can. Procedure can be done in one go or can be done in multiple sessions.
Right.
Some babies may need more than one. So you can do various interventional methods in these patients.
Wow. Okay. And I take it, so, but regardless of methods, so whether you go the surgical method or interventional, are those still based in the same centers you mentioned earlier?
Correct. But majority of those centers do intervention mainly. Surgery is rarely attempted recently, and mainly interventional procedure.
Right. Wow, that's really helpful. Was there anything else that we haven't discussed yet in terms of managing the child?
I don't think so. These patients, of course, will need to have proper assessment in terms of their neurologic ability and neurological development. It must be looked at when the child is growing, and their milestones should be observed. Their head control, sitting up, standing up, walking, talking, speech, these should be checked at regular intervals. Majority of these babies do not have any after effect or neurological deficit, but some might do. So therefore that is important. And also to exclude associated genetic abnormality. That is vital.
Lovely. So I think we've covered for our first category comprehensively. If you had 3 take-home messages for our listeners for this first category, what do you think they would be?
First one?
Yeah.
Listen to head, fontanelles. We added one more auscultation spot. If you have a child with high output cardiac failure and cardiovascular examination doesn't suggest anything, listen to the head.
Listen to the head.
That's number 1. Number 2, these patients require team effort and team input. Neonatologist, cardiologist, and the specialist centers, interventional neuroradiologist. Hence, there has to be a coordination. 3, try to develop your skills on simple usage of ultrasound. Look at the drum mater sinuses. If drum mater or drum mater sinuses are dilated, then it would perhaps support the diagnosis, and it would help your efforts to stabilize this child.
Excellent.
So I hope that is clear. 1. So do you want to describe?
Yeah. So 1, go and listen to the head. 2, this is a multidisciplinary effort. We need neonatologists or perhaps pediatricians if this is a later presentation, cardiologist, and the specialist centre neuroradiologist. And 3, develop our skills in ultrasound scanning. So as we think about looking at the dura mater, because that might be supportive for a diagnosis of a vein.
Confirmative, in fact.
Confirmative, oh, there we are.
That's right. And if you want to expand on ultrasound, also develop your skills on cardiac scan. On 3 things. Look at the function of the heart, chamber sizes. You're looking at 3 things, nothing else you need to look at. Chamber sizes, function of the heart you need to look at, and the other thing you need to look at with the ultrasound in the heart, is there any effusion? 3 things, pediatricians. We're not expecting or we're not asking you to learn many. And it's easy to detect those 3 abnormalities at your level, in my view.
Excellent. Right. Thank you very much, Professor Orhan. Professor Uzun.
No problem. So you're not the first one misspelling it.
And I just wanted to say thank you to Professor Orhan Uzun for recording that episode for us. Partway through that episode, I went off on a bit of a tangent to discuss how paediatric trainees could develop skills in echocardiography throughout their training. So if you're interested in such a thing, please keep on listening.
Anything else? Do you think we should elaborate on the treatment? Or?
Oh yeah, it'd be good to get to the management. But I just wanted to say that I agree wholeheartedly with this idea about paediatricians learning at least some basic echocardiogram skills, and it's something that I'd love to be doing myself in the future. This is a complete aside, but what would be your tips for general paediatricians or paediatric trainees who are interested in developing their skills in echocardiography?
Put a special request in your program lead.
Yeah.
That you would like to do rotation with cardiology. And if possible, you may spend additional time towards the end of your training and come and get more exposure. And I would fully recommend you guys to attend 1 or 2 courses and also acquire 1 basic echocardiography book, whether it is hard copy or online, and that is the starting point. And the other thing is, we're all happy to have you in our clinics. You try to find from your busy schedule to come and join us, and don't hesitate to ask questions, because time is moving very rapidly, and the knowledge has to be shared between the team members. It shouldn't be left to the individual who may be 1 or 2 in the group, but pediatricians are many, and therefore we should make this available everywhere to remove health inequalities and make sure that everybody will be comfortable in managing these patients, and the patients also will be safer.
Yeah,
if you think about it.
Yeah, absolutely.
So come and talk to us, join our clinics, acquire a book, attend 1 of the courses, prepare yourself, and arrange your rotation. That's what I would recommend. If you're more enthusiastic, then take perhaps additional a year to do cardiology interest.
Brilliant. Thank you very much. And this is a final thank you to Professor Orhan Uzun for providing that advice for us. Tune in again next week, where we'll have the next episode in this series focusing on atrial septal defects. Thank you for listening to Dragon Bites. you.